Oh, hey, Chris.
Hey Chuck, how are you?
I'm good. I'm good. How are you? It's a beautiful day.
It's a beautiful day. Nothing like a Sunday morning doing a podcast, but looking forward to the rest of the day, which will be amazing.
Oh, this will be fun as always.
It's
As
perfect. It's
always.
perfect pool weather. You're one of the people that convinced me to invest in a pool, and we had great use of it yesterday. Nice ROI. We'll have more of it today. It'll be great.
So clearly it's heated, yes?
Oh yeah. No way I'm doing that without it.
Your kids wouldn't care because kids are immune to cold.
They are, but I don't keep mine as warm as some of our partners do. I'm about 5 degrees shy of what others do. I won't call them out. But one is a peds ortho surgeon and one is a joint replacement surgeon. They keep it very warm. Mine is not there, but I do like it nice. I like a solid 84, 85. Again, I can see the money just evaporating off of the pool, but the more I get in, the better I feel.
So you don't cover the pool when you're heating it. It's just you're heating the world around you.
I wish it's so nice, Chuck. It's just spend hours in there. It's so great.
Well, I just look at my pool because no one goes in it. It drives me absolutely crazy, but it's beautiful
I
to look at.
I know. I think I'll have that feeling in 10 years when everybody's out of the house. But right now, everybody loves it. And like you said, people want to come over. I'd like to think it's the food, but it's probably the pool.
It'd be a combo. It's an attractive destination for both reasons.
All right, so we're going to
Uh,
catch up a little bit today, talk about your trip, and also go through some listener mailbag questions and go through some cases. We're long overdue to get to our mailbag, and we do appreciate everybody for writing in and telling us what they want to hear about. So, Chuck, what have you been up to recently?
yeah, so I just got back, and this pod will drop in a couple weeks. So I just got back from Atlanta for the Pediatric Hand Study Group, which is just an interesting concept that has been so successful. Started honestly in the late 90s. There's a couple of friends getting together, talking about interesting pediatric hand cases, really congenital cases, evolved into a formal meeting in 2002 and now has evolved into really something amazing. There was probably 120 people at this meeting. It's unique. And Anne Van Hees phrased it as an orphan group. Oh my God. Because it's a mixture of hand surgeons, both plastics and ortho, hand therapists, some trainers, some prosthetists. It's really interesting.
How does how does this meeting continue to get funded? Just in terms of like, do people self-fund for the whole thing, or is it because it's like you said, it's not like formally affiliated with any organization.
Yeah, it's self-funded, and there's been exploration. Should it be the Hand Society or POSNA? But we really don't fit with any of those groups, so it's interesting. And Checkpoint Surgical was a the first time we've had a sponsor, which was really nice.
That's great.
Um, Helps offset some of the costs, and it's pretty simple. We fly in Thursday night, get together, just informally, all day Friday, half day Saturday with a social event on Friday night. But a couple interesting things. One, um, Lindley Wall, obviously at our institution, Andy Bauer at Boston Children's, and Apurva Shaw at CHOP are the co-presidents now. They took over from Ann Van Hees and Michelle James and have really taken this to new heights. Um, the second thing is that in Atlanta, sorry, I'm going to pause for a second. At the Children's Healthcare of Atlanta, we were at their new hospital. It's spectacular. So they were amazing hosts. Anyways, it was a great weekend, and it's a combination of panels and presentations and discussions. Like any meeting, it was good. I was on a panel with Scott Oishi, just he and I, talking about radial deficiency. And at one point, I don't know what came up, and he goes, Chuck's probably already talked about this on his podcast, trying to give me grief. And I wanted to say we don't really talk congenital on a podcast, but I just let it go. I took the heat and let it
God,
go.
the people want it, don't they? That sounds amazing. It sounds like a great group. I know that I remember when I was a fellow, you hosting the meeting here in St. Louis, and incredible vibe. Hopefully, I mean, we've talked about trying to do something like that for nerve. There's kind of older groups. The one that comes to mind is the Sunderland Society, which is still active. But it's interesting to think about the role of a closed society in the current environment, so to say, because they still have a couple of closed groups like the Hip Society, the Knee Society, but they have meetings that are closed and open, and Sunderland is one of those similar groups.
Oh, interesting. I wasn't even aware. I mean, I don't know what closed societies I'm not involved in, but not that any of these would be appropriate for me. But Shoulder still has their closed
Yep.
society as well. Huh, interesting. Yeah, it feels a little odd in 2026. I get it, but hand as we've discussed has the hand club environment, which is really an amazing environment. And this sort of serves as one of my hand clubs, I guess, in an extended version.
So if people want to go to one of these future meetings, how do they find out about it? Can they email the handpodcast at gmail.com?
They could. They could also go to the Pediatric Hand Study Group website. The other interesting thing that is increasingly happen is our registry and the study group are moving closer and closer together, which they should. And that's sort of a prism, the pediatric sports group model of combining research and meeting space. I think there's a lot of logic behind that.
Yeah, that synergy is obviously helpful, and really getting people in the same room at the same time will generate a lot of ideas, a lot of cross-pollination of experience.
Yes. And the other interesting thing we talked about was just education and how does a group like this serve as a source of education? Really, we were talking more for patients and families rather than for peers. Obviously, it could go both ways, but there's a real need. AI can step in the void, but I don't know that we fully trust it in the right word, but it probably is not quite ready to do the things that we could do as surgeons.
Right. Yeah, we tried to do a combined kind of research and case or clinical type meeting here. Last year we did. We hosted it. It was funded by an NIH grant, which is obviously going to be harder and harder to get nowadays. But that was really fun, and I think one of the things that came up was the need for patient education. So
Yeah.
before we jump into these cases, we should thank our friends over at Practice Link.
We definitely should. The Upper Hand is sponsored by PracticeLink.com, the most widely used physician job search and career advancement resource.
Becoming a physician is hard. Finding the right job doesn't have to be. Join Practice Link for free today at www.practicelink.com/the upper hand.
So I was going to say it's a month away from your meeting.
From my meeting,
End of
which meeting?
May. Which meeting? The one you're running in St. Louis on Nerve at the end of
Ah,
May.
yes, yes,
That
yes. The
meeting.
WashU Nerve course, which when this
Yes.
drops, there'll still be a couple of weeks for you guys to get spots. We still have a few cadaver experience spots available. It's going to be exciting. The faculty is all from, WashU, either current or alumni, both from orthopedics and plastics. The course will be really fun for those that are participating. And doing both days. Dr. McKinnon is going to host the reception at her home for the course participants, and she's also offering a optional Sunday morning breakfast that she's calling McKinnon Unplugged, in which she will, I think, just take questions, have some presentations, and she's super stoked about that. So thank you for bringing that up, Chuck. There's just been so many things going on that I kind of forgot that was happening in a month.
Isn't Dr. McKinnon always unplugged? Is that
I,
okay for me to say? I think she is. She just says what she thinks.
I think that yes, but I think the marketing behind this hopefully gets people interested in coming.
I love it. It was great reviews last year. I'm certain it's going to be better this year. So congrats in advance, and it'll be a great course.
Thank you, thank you. So a couple of patients. These are cases I have not done yet, but patients I've seen recently that kind of got me thinking about things. So the first one is a patient who is in a polytrauma, has some lower extremity fractures, and his only upper extremity injury is a fifth CMC fracture dislocation. Small piece off of the hamate, nothing big enough to consider fixing in and of itself, but it's pretty clear on his radiographs that he's got some ongoing subluxation of his CMC. He comes in about 3 weeks after the injury. For whatever reason, there was loss to follow up. How do you talk to that patient about what to expect? What do you recommend? And what's been your experience with treating patients in that situation?
Yeah, I think it's a really interesting injury that is at risk of being missed in the emergency department in isolation. And certainly, if there's other things going on, we all know that bigger injuries demand more attention. Um, I first of all, I think these are really fun cases, and I say it in a way to suggest that this patient needs surgery, and the dislocated, either a complete dislocation or the partial fracture dislocation, whatever it is, needs to be addressed. Some will advocate for a CT scan. I don't feel that that is mandatory if you understand, if you have a good sense of what's going on, especially if you're taking the patient to the operating room at 3 weeks, it could be helpful. Often these are fourth and fifth dislocations, but they certainly can be isolated. And the question will become, can you treat this closed? Do you need to open it and fix that shell of a dorsal hamate? What are your thoughts?
So you said a couple of really great things in there. At risk for being missed. One of the things that you and Dr. Calfee taught me in fellowship was that this is where that kind of semi-oblique view is super helpful because a straight lateral is really hard to see. You're not going to see much on a PA unless it is frankly subluxated or dislocated. But the subtle ones are, that's where the obliques are really helpful, and that's where having the opportunity to fluoroscan them in the office if you have a high suspicion. Obviously, there's gonna be swelling and tenderness in that area. Um, Now, you said this patient needs to have surgery. I'm assuming it's because you think there's a risk for post-traumatic arthrosis.
Yeah, it's well. Sorry, let me go back to one thing you said first. Yeah, a plain lateral X-ray can be very hard to interpret. The one clue, and there is an article, I think it was out of Mayo. I'll see if I can find it and put it in the show notes. In which one telltale sign is flexion of the fifth metacarpal shaft. And so, excessive flexion of that fifth metacarpal shaft means it's dorsally dislocated the CMC joint. So that's a good way to think about it. In my mind, we will often treat base of the fifth metacarpal fractures non-surgically and assume that even if they're intra-articular, those will do fine. And many times they do. To me, this is just different. This fifth CMC fracture dislocation is a different bird. And so making sure in our minds we separate those two injuries, I just don't think you can leave the joint malaligned.
Because it will hurt them.
Yeah, I think it'll cause pain. Certainly, it'll cause a clinical prominence. I have only seen a couple that were, I would say, really chronically dislocated, and they were both seeing me for pain.
Now, you mentioned a CT scan. Is that to check out the size of that hamate fragment to see if that's worth fixing, or is there another reason?
Yeah, well, sometimes it's about diagnosis, but it's not mandatory for diagnosis by any stretch. And then second of all, obviously surgical planning. And I don't know that you need it if you have a good sense from plain x-rays of what you're working with. What I would probably do, kind of skip, jumping a little ahead, is get to the operating room and hopefully you can just close reduce it and put a K wire across the fifth or fifth and fourth CMC joints. If that fragment is big enough, it's very satisfying to put a screw in it. And you can go all the way down into the hook, and you're like hitting a home run screw and feel really good about yourself. Or a little kind of two screw plate you can create and put that on. If the fragment's big enough, I think it makes sense to do that. And by big enough, I mean both wide enough and involving a sufficient portion of the joint, which it usually is a pretty minor portion of the joint, but that's where the CT scan can help
When you're shooting for the home run, please don't be long on your screw because we know what's on the other side. It just makes me so
Yes.
nervous. Pun totally intended.
you.
Um, so you mentioned that they come back and they have pain. I remember reading as a fellow the chapter in Greens about this condition. And it's whoever it was in that edition who wrote the chapter saying, you know what? Sometimes you can treat these with benign neglect because if they don't come back, they may never come back. And if they do come back and they have pain, you have a solution, which would be to fuse that joint. Do you think that's a good solution?
I think the right solution is dealing with it acutely or subacutely. Sure. Yeah, of course, you can fuse that joint. And I think the patient, if they're coming back for pain, which is presumably is why they be coming back, or if they're coming back for deformity, which they don't like, and ultimately, again, that the dislocation of the CMC joint flexes the Fifth metacarpal. So what does that do at the MP joint? I'm not really sure. I haven't seen enough of these type of strong opinion. But yeah, you have a solution down the road, but your solution down the road is not as good as your initial solution.
So is this you're 3 weeks out? Is this you book timing wise for the OR? Is this your next available elective day? Maybe at some point next week, or is it a few weeks? What are you thinking? Because you're already in that area where can I get this closed?
Yeah, I would get it done sooner rather than later. I mean, I wouldn't. It's not an emergency. I wouldn't do it tomorrow or on the weekend, but I would try to get it done just because I think it increases the chances of an ability to do a close reduction if that's your plan.
So say you schedule them for surgery later that week, and then they no showed. What do you do now? Just
Well,
asking for a friend.
yeah, interesting. Well, I would make an attempt to get them back on the schedule. I'd make one more attempt to get them back on the schedule. Um, I would let them know that it may have changed the operative intervention and it may potentially require an open procedure, whereas a closed procedure may have worked before. Um, and if they don't show again, then I move on.
So we'll see. I think it's always tough because now in this kind of, at least in our institution with this, the prioritization of block utilization, it's really hard not to get burned again, in terms of, I filled the time. It was fine, but it always makes you a little nervous. So one more case I wanted to ask you about. So this is another patient who came in kind of a delayed manner, was referred to us by our injury clinic, and has a fourth metacarpal fracture, short oblique, minimally displaced. I told him non-op, but what they found, incidentally, was that he has a scaphoid waist non-union, and he was away for a while, put it that way, and could not get medical care, but has pain over that area. Doesn't have any obvious signs of a snack wrist developing, and it's a waist fracture or non-union, and doesn't have any, not that I'd be super concerned about this, but doesn't have any cystic change in the proximal half of his scaphoid. Like I said, he's tender in that area. He has a different fracture, and that's how he came. But what do you talk to that patient about? And had not had an attempted treatment. This was not diagnosed before.
So we had a great discussion at Journal Club. Was that last week? My God, I can't keep it straight. About scaphoid non-unions. And ironically, before I get to your case, I want to talk about my case. Ironically, in clinic that same day, I had a scaphoid non-union come in 7 years out requesting treatment because of pain. And to your point, and the reason I say 7 years out is that in my mind, 5 years is sort of that line. And
Hmm.
we talked about that at our journal club, and you can add a little more context. Where after 5 years, I become a little more skeptical. We know that patients will develop arthritis. It's not always obvious on the X-ray, but even if it is, to the point of the article we discussed, which again I'll put in the show notes, is a little arthritis okay? So that after that diatribe, I'll go back to your case. I think you talk to them. The patient's going to be down because the healing fourth metacarpal, the scaphoid will take a lot longer to heal, but he or she need to make an educated decision, understanding that they will develop arthritis down the road if they don't fix this, but they may need to pay more attention to today than tomorrow. Um, I guess.
Yeah, so I mean, this patient actually came in the same day as we had our journal club, so it was great for continuity of discussion with our stellar resident Carson. Um, so the article that you're talking about was in the April edition of JHS. I believe it was from a series from authors in Japan, and talking about whether you could still treat the scaphoid non-union even if they've developed as late as I think stage 2 snack changes and
Yeah.
still have success. They didn't have any PROs. They didn't have any talk about pain, but they got the things to heal and supposedly didn't have any progression of arthritis and didn't have any reoperations. So, assuming they all did okay. But it was an interesting conversation for sure. So yeah, the patient and I had that talk. And would you get any additional testing at this point, or would you just, he hasn't had an attempt at, solid fixation or immobilization or anything like that. Is this something where what kind of testing would you get and what kind of treatment would you offer?
Yeah, and we can go down a long road of talking about scaphoid non-union. Is very simply put, If the radiographs tell me the story, I'm okay sticking to radiographs. If I'm concerned about the degree of a humpback deformity, I might get a CT scan for surgical planning. If it's a waist, I would not get an MRI. I don't think that changes the care. So it's the question for me is CT, yes or no? And I think if the X-rays tell the story, I don't feel the need to get a CT scan. What about you?
I wanted the CT scan for planning, just because, I wanted to be absolutely certain about whether I'm dealing with a deformity and it does change the approach for me. I think if there is any element of needing to correct in that sagittal plane, that humpback deformity, then I am considering a volar approach, which I don't like doing. And I'm hoping I can stay dorsal on this. Um, so to your point about the MRI, just for the folks that are listening, I mentioned before it's a waist fracture, not a proximal pole fracture. I think if we had a proximal pole fracture or proximal third even, we'd consider whether there is any avascularity of that proximal pole, and that's where the MRI may or may not be helpful. Is that what you were thinking about too?
Yeah, thank you for clarifying. Well stated. And I was just asked to participate in a symposium at the Hand Society in September in Boston, and it's about tips and tricks, and it's sort of a rapid fire tips and tricks. It's a good group. It'll be really interesting. And one of my tips is always go dorsal for scaphoids if there's any chance you can go dorsal, because I, like you, love going dorsal for acute fractures, for non-unions, and you can't always do it, but when you can, man, it is so much nicer.
So the test that I ordered as well is a vitamin D level. Just I'm seeing more and more just vitamin D deficiency, or it's been seeing me. I just have not been diagnosing and treating it. So basically, in any fracture where I'm concerned about healing, and this is one, I ordered a vitamin D level and I just start supplementing them. He told me when he was away, he was indoors most of that time. So we have a we just started supplementing him too. But a fellow Travis Gordon, one of the plastics hand fellows, who's fantastic, has been spending some time with us in the OR. Voluntarily because he wants to augment his education. We were talking about tough fracture cases, and he did mention that at least when he was in training in Canada, that was a very expensive test. So that's one thing to consider in a cost environment. It obviously is very inexpensive to just treat everybody as if they have vitamin D deficiency. So something to keep in mind.
You are right. It's a good point. One that we probably should be emphasizing more and more is if you have a tough situation with a fracture that won't heal, don't wait 16 weeks, which I have done. Get that vitamin D level or supplement their vitamin D earlier. Most of us are vitamin D deficient. I mean, let's be honest. And the negatives of supplementing, to my knowledge, are close to none. And I do believe it makes a difference. It has anecdotally in my practice made a difference for healing those tough fractures.
One of my co-residents, who has had people mention to him the podcast when he's talked to them, but Peter Fabricant is a peds orthosurgeon at HSS now. And he, as a resident, wrote a paper which was super interesting, in which they took vitamin D levels on all of the New York football giants in training camp and had a shocking level of vitamin D deficiency in, kind of healthy, athletic men who are supposedly outside a whole lot. So yeah, I think we're all probably pretty vitamin D deficient.
That's awesome. All right, I want to share one quick case with you. So, seeing an athlete, collegiate high level athlete, soon, who has a nightstick fracture. So, for those
Oh,
not familiar with the terminology, it is a distal one third ish typically, or maybe even a little further distal than that, fracture of the ulna. It's called a nightstick fracture because, yes, exactly. You guys need to go on YouTube to see Chris and I doing the same motion at the same time. You get hit by a baton, typically, often by an officer of the law, and you protect yourself and you get hit right in the distal forearm. And the literature is relatively
allegedly by an
clear.
officer of the law. You don't know whether you're just at the club and things got out of hand, and
True, true. However you are struck, you have a fracture, and the basics of when to operate, when not to operate are pretty clear. Based on gapping acutely and based on 50% displacement. That's what we're taught. In a high level athlete, it's this different equation, so it'll become a patient and family decision, and it hopes to get the athlete back to play faster.
I remember a funny story about that. When I was a resident, this was a common thing that came up. You would have your handbook of fractures, and you would, see these patients, and then you would discuss them in conference the next day. And we had a very overconfident, confident chief resident. Sometimes wrong, never in doubt. And we were talking about radius shaft fractures and ulnar shaft fractures, and he let us know that he thought that the nightstick fracture was a fracture of necessity, which I think he was thinking more about radial shaft fractures. For those listening, you don't automatically have to fix these nightstick fractures. It does depend on your amount of displacement and angulation. But I think if you're trying to get somebody back to play and that's your priority, makes absolute sense. Now, are you thinking plate and screw construct? Are you going to try to go fancy and put one of them little nails, skinny nails down there?
No, I like nails for certain things, but no, I'm a plate and screw guy. Get some compression, and I think it'll speed the process a lot. We did this on one of the Cardinal players a few years back, and it does. It gets people back to play a lot faster.
Does the size or thickness of the plate change based on your return to play, or is it just kind of what fits the bone?
Well, it's a good question because you can make a very good argument to avoid the super thick DCP, not because it won't help this fracture heal, but it is make you more susceptible for another fracture adjacent to the top of the plate. So yeah, it's a good question. Typically I've gone bigger and stronger, but in this patient, it's a young woman. I'm going to have to think about the plate I choose. Maybe a 2.7 DCP might do better.
Now, people are going to ask, is this one plate or two plates?
Are they going to ask? One plate.
People might ask. People might ask.
One plate.
One
One
plate,
plate.
you're able to get good compression through the plate.
I would assume. Yeah, that's why I want a DCP rather than something really simple. Yeah. Yeah, for sure. For
So
sure.
no one-third tubular plates coming out.
No one-third
I
tubulars.
saw an X-ray recently with one-third tubular plate for. I was seeing somebody with post-traumatic tarsal tunnel. I was like, I have not seen one-third tubulars in a long time, but
Yeah,
used here and used very well. A plate is a tool.
absolutely. Yeah, there's absolutely an indication for it.
So
Well,
we've got some quick hits in terms of the mailbag. But before we get to that, speaking of fracture cases, if you've done revision fracture cases, you know how unpredictable anatomy can get: scar tissue, malunions, prior implants, all of it. Checkpoint Guardian Nerve Stimulator gives you real-time confirmation of nerve location and function, even when landmarks aren't reliable.
so you can spend less time searching and more time moving the case forward with confidence. Check it out at checkpointsurgical.com. It's interesting. Especially, as hand surgeons, we like to think that, oh, we'll just find the nerve, which, yes, that's a good strategy. It's not always that easy. And for those who aren't always dealing with nerves, the checkpoint really can be helpful. I don't use it regularly, as you know, but I think there's increasingly indications for considering it.
Just remember you can have tourniquet-related ischemia, so if you are going to use your stimulator to help you, whatever brand you want to use, but in this case, the Guardian, you do have a certain amount of time. The dogma, I don't know what you feel and what you were taught and what you teach people, but people typically say 30 minutes. David Bergen and I wrote a paper that showed that you have at least 45 with this particular stimulator. And full disclosure, Checkpoint did fund that study, but that was helpful for us. But I do tend to get nervous, again, pun intended, after about 45 minutes. And I try to keep my tourniquet pressures relatively low if I know I'm going to rely on using that stimulator at a critical part of the case.
So if you're performing an upper extremity case, or what's low mean to use? At 200 or
A hu-
225?
100 over the map, typically.
Okay.
And I will use 200 if I'm needing to rely on that. That does buy me some time. It doesn't buy you a ton more, but honestly, even 5 more minutes helps a lot.
Interesting. Well, I will bear that in mind if I pull out the checkpoint guardian.
So a couple of listener emails that we haven't gotten to, and thank you for those that have emailed in. One topic that I wanted to bring up was from a hand surgeon who's been in practice about 11 years. I won't say their name just because I didn't ask permission. But their first topic request is regarding fourth extensor tenosynovitis. They don't see a lot of it. They have treated patients for this and have had, quote, pretty terrible results. One patient I treated with a steroid injection had the unfortunate complication of a fluoride infection, which required multiple surgeries. This was after the injection. And then another patient was an avid pickleball player, treated with observation bracing therapy. Symptoms persisted. Went to surgery for a fourth extensor tenosynovectomy with the Z-lengthening of the retinaculum, which was so tight it had caused a spontaneous rupture of the EIP. Surgery went smoothly, but she developed a quick recurrence and was extremely unhappy. So, Chuck, what's been your experience with fourth extensor tenosynovitis?
Well, first of all, thank you for writing in. It's an interesting topic and one that we really, don't none of us see that commonly, but it's highly relevant. We just wrote a paper about this topic and the need for cultures and or pathology assessment in these situations. And so, a lot of thoughts. So, first of all, I don't know that your steroid injection caused the fluid infection. It may have accelerated it. My guess is it was already there, and the injection just, made it come to life more. So that's an important consideration. Um, and then the second thing I'll say is, and there's more to talk about. These are not you may not think that these are long surgeries, but this has to be done meticulously. And it's not a quickie on the OR schedule that you just put on between carpal tunnels, 20 minutes or whatever. Depending on the degree of the tenosynovitis, that fourth compartment does need to be opened and addressed. And my guess is the EIP rupture you talked about probably wasn't caused by the tight retinaculum. It was probably caused by the tenosynovitis, which is the fear we all have with chronic tenosynovitis. So I babbled a lot, but what are your thoughts?
I wonder if this condition has seen me more than I've seen it. I think that, the main thing I would think of is tenderness in that area. It may present similar to a ganglion in a lot of ways, but I think it definitely comes up. Their tenderness spot is slightly different. Do you see a role for an ultrasound? And I think that we perhaps are not seeing as much of this because of the, influence of DMARDs. Do you think of this as something that often comes up in inflammatory arthritis population, or is this something that can happen in anybody?
So I think for me, there's sort of three populations. One is an inflammatory condition, and you're right, DMARDs have dramatically affected that. Second of all, it can be an infection, and classically, we're talking about an atypical mycobacterial infection, and that's what we worry about. But that's when we might see it. So that has to be in mind. That's the rare occasion I ask about fish tanks and water exposure and the weird stuff. And then lastly, truly idiopathic, and sometimes that's like incidental finding on an MRI for another reason. And sometimes it's an ultrasound or MRI to evaluate why there is persistent swelling that doesn't look just like a ganglion. So all of those things are in play in my mind.
Yeah, the only other thing setting in which I've seen this, and I was put onto this by one of the hand therapists, Lorna Kahn, is in the setting of a recovering ulnar nerve palsy or recovering ulnar neuropathy, and they're really using their extrinsic extensors a lot to try to compensate. You can see they will have pain in that area, and it is helpful to mention that to them. I don't know if it warrants moving forward with any additional treatment, but that's one setting in which this can come up as well.
That's interesting. Yeah, I don't think I've seen that, or again, it may have seen me, but I didn't see it. But yeah, it's an important diagnosis, and I know that the surgeon who wrote in is not alone in their, I guess, exasperation with this diagnosis. But I do think we can treat it effectively with proper thought and consideration, and honestly, conversation with the family because recurrence is a risk. I've been there, and we have to make it clear before the first surgery that may or may not be the solution, permanent solution.
Before we move on, you mentioned the importance of meticulous technique. I think there's an entire generation, in my generation, of surgeons, of hand surgeons, who does not have the experience that we used to have with doing a tenosynovectomy because DMARDs, to be honest with you. So how does one do a extensor tenosynovectomy very well?
Yeah, I would say maybe a few points. First of all, you don't have to take down the retinaculum. I certainly have, but I try not to. I try to work proximal and distal the retinaculum, pulling the tendons to and fro, so to speak. And then it's just a matter of being meticulous, tendon by tendon. I think a knife is easier than scissors, and taking off any of the tenosynovium that is abundant there. And again, you really want to try to get it all from proximal to distal. And you have your five tendons in your fourth compartment. I always check the second and fifth compartments as well. But usually in this type of situation, it's isolated.
I like the scalpel for this as well. I think that if you start using your scissors and spread, you're just gonna get lost in tissue planes that you keep creating. So direct visualization, being definitive and intentional with your use of the scalpel, I think is very helpful.
So, Chris, you implied that you were a different generation. What generation are you?
I'm 11 years in practice now, Chuck. So I think I'm officially mid-career once you're in your second decade of practice. But
So
I'm
you
I'm I'm
are,
of the generation that didn't get to do a lot of RA surgery.
gotcha. But I'm thinking like general. So I'm a Gen Xer. You must be a millennial. I think you act like a
I
millennial.
I'm an exennial. I'm actually on the border of the two.
You're on the cusp.
I am. There's an actual like shoulder period between the two, the gray area, so to say. So let's get to this. This listener also emailed another topic request. So my second topic is CMC arthritis with Z deformity. I currently perform my CMC arthroplasties with internal brace, suture tape suspension, and APL suspension plasty. Taking a slip of APL, harvest proximally, weaving it around the distal FCR and the anchovy, the remnant, into the space. If there is significant MP hyperextension, I will fuse the MP joint. Most of my patients do well with this, but for ones with severe Z deformities, especially with first metacarpal flexion deformity changes, I find it really difficult to correct the collapse. How do you address treating these patients? Do you find success in correcting long-standing Z deformities of the thumb?
And we also recently had a discussion about this in our Monday morning conference.
Mhm.
Yeah, it's a great question. So I think that most of us feel two things. Number one, CMC arthroplasties, however you choose to do it, these arthroplasties do well, whether it's suture suspension plasty, whether it's a suture tape augmentation, whether it's a LRTI, whatever you want to do, most do well, assuming the surgery is technically done well, but there's a population that don't. And that can be from either the CMC joint or the MP joint. I feel pretty strongly that you can control the MP joint by your procedure at the CMC joint. Best done with the fusion of the CMC joint if that is in play, not in an older patient typically. We've talked about this. We can control the base of the metacarpal and pull it volarly from its, out of its subluxated position and pull it volarly with whatever technique you choose. That's the beauty of the LRTI. It does it automatically with an LRTI. But with the suture tape, you have to take an extra step to bring the metacarpal down. That may not be enough for a severe Z deformity. And I agree with the listener that the best option is to fuse the MP joint, especially if you keep the CMC mobile. I've tried to get away with different things over the years, and I still try to get away with doing nothing. But a fusion often is the best solution.
I think the Z deformity is very humbling. It's a challenge, and I think you have a specific technique and a way that you use your suture tape. Maybe you could share it to control that additional sagittal plane deformity. But it is very hard to deal with, and once you get to the point of having a Z deformity, I have a low threshold to fuse the MP joint, assuming I'm not fusing the CMC. I don't want to speak for him, but I know one of our partners, Marty Boyer, has leaned more towards CMC fusions in a population you wouldn't typically associate with CMC fusions to really get control of the MP joint, and he feels like he can do that pretty confidently. Again, not don't want to speak out of turn, but yeah, how do you use your suture tape to help correct that the metacarpal um, base dorsal subluxation?
Yeah, I do. I do think CMC fusions have they've sort of, the pendulum has swung too far, too fast towards don't do it. I think it's a great operation in the right patient. And Marty Boyer's population tends a little older than mine, so we don't think as much about it. But again, to control that complex deformity, including the CMC and MP, it can make sense. So when I use suture tape, I will leave the needle on the suture tape. And once I've secured my anchors to the thumb metacarpal base, and the second metacarpal base. I will then take that suture and go through the dorsal base of the metacarpal, the first metacarpal, and then come back down and tie it onto itself. So in doing that, I'm pulling the base of the metacarpal down or volar, and that reciprocally affects the MP joint. So it's a really easy addition. The only negative to that approach is it makes a little bulk there at the dorsal base of the metacarpal where the knot is. But honestly, I don't have patients complain of that. I try to cover it up with the capsule. But it can be a nice tool, and I think it does help me control the MP joint very effectively.
Any issues passing that needle through the bone, or is it typically pretty easy? Do you have to make a little pilot hole with a K-wire or anything like that?
Well said. Usually it's a stout needle, at least the one I use. So you usually can pass it through, but I don't fight it. And so drilling with a K-wire can absolutely make the difference. And just like those of us who used to do the old LRTI, you got to be careful that you don't break off the dorsal metacarpal. So that's where a K-wire can come in instead of fighting too hard.
Yeah, that bridge is critical, and you don't want to be in that situation. I
Yeah.
remember being close to that with Dr. Gelberman at one point, and it was a little stressful. So one more, why don't we do one more listener email? And this is a nice one from a surgeon at the Monkey Clinic. And I won't say their name again because I didn't have a chance to ask them. But he did mention our recent episode about ulnar nerve transpositions and asking about just in general, theoretically, why would you put a nerve underneath muscle where it might scar to muscle? And I'm paraphrasing because we know that nerves love to be around fat. So why don't we always put the nerve around fat? And why is it okay for the nerve to be submuscular? What's been your experience with that? Have you found that nerves have scarred back to that muscle, or do you feel like they typically look okay if you have to go back in?
Yeah, it's interesting. I certainly have had patients in which treatment with a submuscular has not been the ultimate solution. I am not a surgeon who prefers to go submuscular. In fact, I try to avoid going submuscular. I wouldn't say it was necessarily for this reason. I just think it's a lot of trauma. I don't like any procedure where I have to cut a lot of muscle. That's a really interesting question. It's a really important question. I do like my nerves surrounded by fat when I do a transposition. So I'm really curious as to your thoughts.
Yeah, I mean, ideally, you'd have the nerve in fat all the time. I guess and we brought this up before, and this listener brings it up in his email. Um, that that course of the ulnar nerve, if you put it underneath the muscle, it is just a straight shot, and it doesn't go up and then back down. Whereas if you put it subcutaneously, wrapped in that beautiful layer flap of fat that Mal Rosenwasser published on, it does have to go back up and then come back down, which I think in some cases might be an issue. And I think I've thought about this quite a bit. I think the reason that we can, get away with it in terms of putting it underneath the muscle is that if you get the patient moving early, you're going to get that nerve to glide. And, it has worked out well for me. And that was teaching that I got from our group and also in talking with Dr. McKinnon during training. And I was actually doing a ulnar nerve transposition with a medical student and a resident, and the medical student, Ethan's very smart. Um, he brought up the point. He's like, "Well, actually, are you really putting it underneath the muscle? Because the way I do my transposition now is that actually you take the muscle, the flexor pronator mass, off of the bone, which again makes me a little concerned that the nerve is right on the bone, but that also gives the nerve the straightest shot because it doesn't have to go around the little bumper of muscle and then come back down. And I think that really releasing that, so the posterior part of the flexor pronator mass, making sure that that is recessed distally to make sure that that nerve has a straight course and will not kink at that level because that is where it will often kink.
Well, a couple of thoughts come up. Number one, I agree, keeping nerve away from bone is really important. Maybe at least as important as keeping away from muscle. Number two, that is, this discussion is why intramuscular transfers or transpositions fell out of favor. For me, it's pretty clear. As some still do it and believe in it. I've seen scarring with intramusculars. I haven't done that operation in many years. Third of all, so you're saying you don't do a Z lengthening of the flexor patellar mass, you just take it directly off the bone and reattach it?
I lengthen the fascia, Z lengthen the fascia, and take the flexor pronator muscle off of the bone. And then the posterior part, I make sure to really recess that distally. And it all just kind of falls back. And obviously not going deeper than my brachialis, deeper than my capsule, and not compromising my MCL.
And does this ever cause an aesthetic, visual difference on the medial proximal arm. So, just distal to medial epicondyle. Sometimes I see a little deformity there, and I wonder if that's retraction of the flexor peroneal mass. Do you ever see that?
Oh yeah, all the time.
Do you
And
care?
I tell them about it. I mean, so and they're like, "What's this?" I'm like, "That's where we, move the nerve." And they're like, "Okay." So has not caused any consternation aside from having to answer that question.
Cool. Love it.
All right. Yeah, so thank you to the listeners who have emailed us with questions. Please continue to send them. I promise you we'll work through the mailbag a little bit more expediently. I will close by with a nice email from Clifford Johnson, who has given us permission before to use his name. And he does say he listens while doing yard work or farm chores and always forgets to send an email when I'm done. So thank you, Cliff. Upper Hand has served as a great starting point for conversations with our hand therapists and PAs. So thank you for listening to Cliff's PAs and hand therapists. He did say that the video the Mayo Group posted of Dr. Bishop's honor walk after his last OR day gave me chills. I'm worried we're losing that sort of honor and respect in medicine. It is great to see that is still alive and well at Mayo. So thanks, Cliff, for the email. Again, email us if you guys have any topic requests and or feedback. And I hope everybody has a great week.
Yeah, I love that close. Thanks. This has been fun.